Madam, we are live now. Shall we start?
Yes.
So, good evening, Dr. Aishuman, on behalf of Shield Healthcare, welcoming you all in another very interesting and important session with Dr. V. Sarada Madam on pelvic infection disease and female infertility. But before moving into the session, let's have a look on our Shield Connect platform, that is a knowledge sharing platform of Shield Healthcare, where we regularly conduct many medical CMEs across India. So this is the blog section. Here you can find different blogs written by many eminent doctors in various topics across India. These are the blogs you can see. And these are the webinar section, means the upcoming webinar section currently. And this is the PCOS awareness blog. Here you can find all the related information on PCOS, and that talk is available in many regional languages like Hindi, English, Malayalam, Tamil, Telugu, and many more. Apart from that, this is another one menopause awareness blog. Here you can find all the details on this menopause. And this is another section on gestational diabetes mellitus. Here you can find all the related information on gestational diabetes. And the most important thing is our key opinion leaders. So presently more than 500 doctors are currently supporting us, this knowledge sharing initiative of Shield Healthcare across India. So now it's time to start the session with the madam, and it's my honor to introduce Madam Dr. MBBS TGO DMRD and Diploma in Reproductive Medicine, KL Germany. Madam is trained in reproductive medicine at EARTH Mumbai, Triple Chennai, and IDK from Ahmedabad. And apart from that, in academic activities also, Madam presented many research papers in many international and national journals as well. And she presented in APCOG 2015 and API-ACR 2019. And presently, Madam is addressed as a consultant at Rohini IVF Center, Amalapuram. So with this short introduction, I request Madam to take over the session. And meanwhile, I request all the participants for your active participation, and please post your queries on the QA dashboard of the Shield Connect page. So once the talk will be over, we shall have a short discussion on this topic with Madam. So thank you very much, Madam, for your valuable time on this Shield Connect platform, and over to you for further proceedings. So thank you very much.
Okay, live on YouTube, connected. Am I okay? Am I audible?
Yes, Madam. You can share your screen and start.
Okay. Okay, thank you for the kind introduction, Dr. Sumar. Good evening, one and all. Can I start my seminar?
Yes, ma'am.
Yes, okay. Is the screen visible now?
Yes, Madam. Fine.
Okay. Okay. Good evening, everyone. Today, the topic I am going to discuss is pelvic infection disease and female infertility. I particularly chose this topic today because I thought as gynecists and obstetricians, we all should not forget our basic teachings. A basic teaching in the medical college, like history taking, clinical examination, a per speculum examination, a per vaginal examination, which are so fundamental and so very, very important in case of especially pelvic infection disease, because without which we cannot at all diagnose a pelvic infection disease. No matter whatever advanced we are in our diagnostic technology, we should not forget our fundamental basic history taking and clinical examination, especially in pelvic infection disease. Now in this COVID era, we now that we have practiced a non-touch technique for the last 2 years, I think now that the pandemic is ending, we should all go back to our basic teaching of touching the patient and doing a speculum examination, without which we cannot diagnose a pelvic infection disease. So, let me tell you first what is a pelvic infection disease. We all know that pelvic infection disease implies an inflammation of the upper genital tract, which includes the ovaries, the fallopian tubes. Most of the PIDs are of an ascending infection type. Some are, of course, bloodborne. So the lesion is usually bilateral. Sometimes a single tube can be affected, of course, but the typical presentation of bilateral lower abdomen pain suggests a pelvic infection disease. The ovaries are so closely linked to the fallopian tubes anatomically that they are coincidentally involved in the infection. Except we have an exception where in mums we have only uvaritis without the fallopian tube being involved. Now coming to an overview, what is PID? It is a major comorbidity in the young sexually active woman. The prevalence of PID is increased worldwide now. Usually it results from sexually transmitted pathogens ascending from the lower to the upper genital tract. As the picture in the side of the slide shows you that the bacteria and the port of entry of the bacteria is through the vagina, through the cervix, into the uterine cavity and the fallopian tubes and the ovaries. Pelvic infection disease is important as it can have long-term sequelae. Why is it so important is we are scared of the long-term sequelae. Now here is a picture showing you how the infection looks like when it is really in the live. Like if it is endometritis, there is an irregular endometrium. A tubo-ovarian abscess can be seen on ultrasound. If the infection is from the ovary, it is uvaritis. If it is the tubes, it is salpingitis. And if it extends into the pelvis or peritoneum, it forms a pelvic or peritoneal abscess. Now, the pathway of the infection is mostly an ascending infection, as I have told you, but sometimes it is bloodborne also, like in case of tuberculosis. So first, the infection starts at the cervix gets infected, it is cervicitis, then it carries on into the endometrium, causing endometritis, and the fallopian tubes, it is salpingitis, uvaritis, tubo-ovarian abscess, and peritonitis. Now let us see why we are scared about this pelvic infection disease. Because it leaves long-term sequelae in the patient. What are the long-term sequelae? One is chronic pelvic pain and infertility and ectopic pregnancy. Infertility because of the bilateral tubal blocks, and ectopic pregnancy also has the same reason because of the tubal blocks. The oocyte cumulus complex cannot be moved into the uterine cavity. Now let us see what are the causative organisms causing pelvic infection disease. Actually, the causative organisms I've seen on the slide are only two, like Neisseria, gonorrhea, and Chlamydia trachomatis, because they are so very important. But the organisms can be divided into those sexually transmitted infections and the pyogenic infections. Now, the sexually transmitted infections, we have the Neisseria, gonorrhea, Chlamydia trachomatis, Mycoplasma hominis, and Trichomonas. And coming to the pyogenic infections, we have the aerobic as well as the anaerobic infections. Aerobes, we all know that Staphylococcus, Streptococcus, E. coli are the most common ones. In anaerobic infections, we have bacteroids, Clostridium, and actinomyces. Especially actinomyces, which is caused by insertion of an IUC. And we should not forget tuberculosis also, because tuberculosis salpingitis is so very common in India. But tuberculosis itself is an entirely different chapter. I will just give you a brief introduction of tuberculosis pathology also in this webinar. So now, coming to PID, it is now by now we understood that it is a polymicrobial infection. Neisseria, gonorrhea, Chlamydia trachomatis, this is how it looks on the pathology slide. And other infections are Gardnerella vaginalis and anaerobic infections. Now, who are the patients who get PID? These are young patients less than 25 years who are sexually very active, and patients with multiple sexual partners and with a past history of sexually transmitted infections. History of termination of pregnancy, if they have any history of termination of pregnancy, and procedures which are involved in IVF like hysterosalpingography, hysteroscopy, the oocyte pickup, all these procedures are inherently inbuilt into having pelvic infections. And smokers, because of decreased resistance, they also are prone to pelvic infection disease. Coming to the symptoms. Actually speaking, a good proper clinical history taking and clinical examination, we can come to a conclusion that the patient is suffering from pelvic infection disease. Now, what are the symptoms? Sometimes some patients can be totally asymptomatic also. We have to diagnose by our own techniques of speculum examination or vaginal examination. Now, if the patient is symptomatic, what is the symptom of pelvic infection disease? Typically, the patient presents with a lower abdomen pain, which is on both sides at the site of the tubal region. A temperature greater than 38 degrees centigrade, deep dyspareunia, chronic pelvic pain, and abnormal vaginal bleeding. Whatever it is, post-coital bleeding because of cervicitis and erosions of the cervix, and intermenstrual bleeding because of some polyp or in the cervix or in the uterine cavity which gets infected can cause bleeding, and menorrhagia. Menorrhagia, we are always worried about the hormonal disturbances of menorrhagia, but there is an element of infection which we have to rule out before going for hormonal treatment. Associated, if there is a hormonal pathology also, you have to treat simultaneously both for the hormonal pathology as well as the pelvic infection disease. Now, abnormal vaginal or cervical discharge, which is often purulent, is one of the symptoms of pelvic infection disease. Having said the abnormal vaginal discharge, let me just go to a basics, one of our basic slides which we must have not revised for long. Today, I have just put up this slide only to recollect ourselves that that we forgot our speculum examination and how much information a speculum examination gives. Once you keep a speculum, you come to a conclusion so simple, and it is to diagnose abnormal vaginal discharge. So first, before talking about abnormal discharge, we should first know what is normal discharge. Normal amount of white discharge, which is odorless without itching, is physiological. The patient is best reassured in such conditions. Sometimes it is a running white discharge which stains the clothes, like we call it leukorrhea. This is seen especially as soon after birth and during the puberty, just when the uterine genital areas are being developed, and the oral contraceptive pills and pelvic congestion can cause this type of leukorrhea. Non-infectious causes of vaginal discharge like a foreign body or a polyp or allergic vaginitis can also cause leukorrhea. In these two types of discharge also, you can just counsel the patient for the specific pathology and and once the cause is removed, it is treated. Now coming to abnormal vaginal discharge. Then abnormal vaginal discharge is that which is so increased in amount that sometimes the patient has to use pads even for the discharge. It has a malodor, it causes itching, and it is discolored. It is not white in color. So now this is the pathological discharge. So once you feel that the discharge is pathological, it is your responsibility that you diagnose what is the cause of this infection. If you find the cause of this infection, you can go for a specific treatment. That is most important. That is what I wanted to stress today in this slide. Now, you can see with your eyes, if the discharge is fishy in order with a thin gray colored discharge, do a whiff test with KOH. You find clue cells. It is diagnosis of bacterial vaginosis. So clear you have a diagnosis of bacterial vaginosis, and so good you have the treatment of bacterial vaginosis, that a simple speculum examination is enough for you to tell that this patient, if you don't treat this infection at the early stage, this is the one which goes above and above, breaching all the barriers, the cervical canal, the uterine cavity, finally into the salpings, causing salpingitis and causing all the trouble of long-term sequelae and disturbing the fertility of the patient. That is why it is important that we go for a speculum examination, which I insisted in right from the beginning of my topic. I'm telling about speculum examination, per vaginal examination, a good clinical history, and clinical examination is a must to diagnose a pelvic infection disease. Now, again, coming, if you see a curdy white discharge, which is adherent to the walls of the vagina and causing pruritus, do a KOH test where you see hyphae, and it is a diagnosis of Candida albicans. You make use of the microbiology department when you see a white discharge. Take a cervical swab, send it to the department and get a diagnosis, and then go for the treatment. Meanwhile, you can prescribe a general antibiotic as well as a vaginal cream for her pain relief. If the discharge is profuse, malodorous, pruritus, now it is associated with pruritus and yellowish green in color with a strawberry vagina. Typically, it is a trichomonas vaginitis. Wonderful treatment with metronidazole BD for 7 to 14 days. Now, if you have any cervical lesions, a speculum examination can make you see the cervical mucus, whether there is any erosion of the cervix. Nebotian cysts are there, which suggests of chronic infection, and cervical tenderness, a lower abdominal pain. Do a pelvic per vaginal examination, see whether the fornices are tender. If there is cervicitis, the infection, usually cervicitis, is with gonorrhea and chlamydia, thus leading again to pelvic inflammatory disease. Pelvic inflammatory disease don't allow this infection to go to the uterine cavity and the fallopian tubes. Treat it as early as possible. Go for a pap smear, do a colposcopy, and if you find any abnormal lesions, you can do local therapies like electrocautery or cryo. And give a single dose of azithromycin 1 gram orally and doxycycline 100 milligrams BD for 7 to 14 days will cure the disease in the early stage itself. So having covered the main symptom of vaginal discharge, let us see what are the signs. Now, sign is something which we should elicit. Fever, yes, you see the temperature. If it is high temperature, suspect infection. Lower abdominal tenderness, yes. Cervical motion tenderness on bimanual examination, that is the fornices are tender. Abnormal vaginal or cervical discharge, which is often purulent as shown in the picture for gonorrhea as well as for chlamydia. Now, though the clinical signs and symptoms lack sensitivity and specificity, first come to a conclusion with this signs and symptoms, then go for the diagnostic techniques. Now, differential diagnosis. How do you differentiate this lower abdominal pain from the other conditions? First, you have to rule out ectopic pregnancy. Of course, by history of amenorrhea and with a high beta HCG level and ultrasound, you can rule out ectopic. If there is no intrauterine gestation sac and the gestation, if you see a gestation sac in the adnexal region, you can rule out ectopic. Ovarian accident. Now, what is ovarian accident? It can be a torsion of the ovarian cyst or a hemorrhage of the ovarian cyst. This can be easily seen on ultrasound. With the if it is a hemorrhage, you have bands and echoes into the ovarian cyst, and if it is a torsion, you will not find any vascularity in the cystic region of the on ultrasound. Appendicitis, yes, by clinical, again by taking a good history, fever, pain, vomiting, and right iliac fossa tenderness, and an ultrasound examination of a blind end bowel loop in the right iliac fossa above the iliac vessels will clinch the diagnosis of appendicitis, and you can rule out appendicitis. And it is usually towards the right side. You won't find it bilaterally. Irritable bowel syndrome, inflammatory bowel disease, urinary tract infection, all these have to be ruled out. A bowel torsion. Last but not the least, that is psychosomatic pain is an ailment when you exclude all this, and if you don't find any cause, think of psychosomatic pain. So having come to a diagnosis, the investigations, what are the investigations available still for us to diagnose a PID? Because we are still lacking a sensitivity in all these methods, which I have told you. Now, blood test, go for a CBP. Complete blood picture, you find a raised WBC count, a neutrophilia suggestive of acute inflammatory process. And if it is a reduced WBC count, sometimes this neutropenia is seen in case of severe infections. And a raised CRP and ESR is also seen in case of acute infections. Coming to the microbiological tests, I will be talking about Neisseria and Chlamydia trachomatis. If you find a purulent white discharge spouting out through the cervix, do an endocervical swab. It should be placed in a transport medium and it should reach the lab as early as possible within 6 hours. If not possible, at least within 24 hours. Otherwise, the viability of the organism will be lost. And once you send it for culture, you find the growth and confirm the diagnosis and start the treatment. Chlamydia trachomatis, similarly, you send an endocervical swab for chlamydia, that is, they do it by the NAT test, because we have to know what is happening in the lab end also. Nucleic acid amplification test is being done there because culture, it is more sensitive than culture. And once chlamydia is diagnosed, they give you the test. You can go for the treatment. Sometimes you can do this test by collecting non-invasively also the specimens from the urine and vaginal swabs also in case of chlamydia trachomatis. Just I kept a slide of pelvic tuberculosis because without pelvic tuberculosis, I didn't feel like discussing this topic of pelvic infection disease. This pelvic tuberculosis, it can remain dormant and asymptomatic in a patient, or it can be an active symptomatic tuberculosis. Pelvic tuberculosis, let us know that it is a paucibacillary disease. It is not multibacillary disease. So the treatment is also for a period of 2 plus 6, 4 months for 6 months with the 4 standard drugs of tuberculosis, ATT. What are the symptoms in case of pelvic tuberculosis? If it is asymptomatic, you have to elicit whether she is having a past history of tuberculosis, a family history of tuberculosis, and persistently thin endometrium is one of the, whenever you see a scan and you find that the endometrium is abnormally thin, suspected tuberculosis, because there must be some scarring on the inside the cavity. If you do a hysteroscopy, it will definitely clinch the diagnosis. Take a biopsy and send it to the pathology department. Recurrent pregnancy loss, history of recurrent implantation failure in IVF, all these should suspect some infection disease going on in the endometrial cavity. If the patient is symptomatic, of course, it is a little bit easy to diagnose. You have a discharge per vaginum, pain abdomen, a low-grade fever running throughout with ill health, a mass in the abdomen, and hydrosalpinx, pyosalpinx, and finally infertility. The patient can present to you with any of these complaints. So next, how do you investigate in case of tuberculosis? Do the routine investigations, again ultrasound, see for any of the mass lesions like hydrosalpinx, pyometra, and do a HSG, typically the T-shaped uterus you find with the scarring of the endometrium. It is highly suspicious of tuberculosis. And go for a routine endometrial biopsy. Laparoscopy can diagnose. Histoscopy, as I told you, you can see very cheesy white endometrial cavity. When you scrape, you find cheesy material coming out of the cervical canal. So histoscopy guided biopsy, MRI, CT, PET scan, again, the advanced techniques are used when you cannot diagnose with the routine techniques. So once you confirm the diagnosis, you have to confirm the diagnosis by histopathological examination, TB PCR test, expert gene test, or AFP culture. So all these tests are confirmative. If you find positive of any of these 4 confirmatory tests, go for the ATT treatment. That is 4-drug regime. Standard treatment is enough for pelvic tuberculosis. That 4-drug regime, but the initial 4 drugs for 2 months and then 2 drugs for the next 4 months is enough in case of pelvic tuberculosis. Unless you find it in a severe stage with pouting abscess and all, then you have to go for 9 months regime. Any of these tests are negative, if the confirmatory tests are negative, you need not start an ATP. So treatment not to be started on sole PCR positive, gene expert and AFP culture are gold standard tests. Now, how do we manage? I told you in medical therapy, first line therapy as per WHO guidelines, standard treatment of for 6 months. And if it is resistant, then go for the second line drugs also. And when to treat, I have told you when the tests are positive. When do we need surgical management for case of tuberculosis? When there is a hydrosalpinx, pyosalpinx, a tubo-ovarian mass, pelvic adhesions and peritonitis, and Asherman syndrome. Remove all, break all the fibrous tissues, go for estrogen progesterone therapy for at least 3 to 6 cycles, and then plan for a fertility treatment. And if the patient is history positive or clinical examination positive, when with all these conditions, you have to go for a surgical management. And when do you go for ART procedures? Definitely, if the tubal factor is there, if you have bilateral tubal block, you have to go for a ART procedure. And combined with female fertility factor, if there is a male factor and the age of the female partner and third party reproduction, if indicated, if you find that the endometrial cavity is so very bad that it cannot take up an embryo, then you have to think of third party reproduction. So this is in brief, I covered pelvic tuberculosis because this is also very important in case of pelvic infection disease. Now, what are the radiology investigations we have? Ultrasound. Ultrasound will definitely give you a clue that the patient is suffering from pelvic infection disease. It is definitely helpful, but it is an indirect evidence. You cannot get the definitive diagnosis of that which infection it is. You can only know that there is an infection. What are the indirect evidences in ultrasound to know that it is an infection? One is if you see a tubo-ovarian mass, a tubo-ovarian abscess, or if there is a collection into the pelvic pouch of Douglas. And all collections are not pelvic infection. Whenever you see about 5 to 10 ml collection, don't think that there is some infection. And if you give a report of PID, then starts the treatment of 14 days of doxycycline metrogyl. So sometimes you first find out in which phase of the cycle she is. If she is in the follicular, just exactly ovulation phase, and maybe she has ovulated. And if she has ovulated, there will be a little amount of fluid in the pouch of Douglas. It is not a PID. So if the fluid is significant amount, and if the fluid is persistently there for a long time, even on repeated scans, definitely you have to think of a PID. Why will the fluid collect in the pouch of Douglas? It is only because of infection in the tubes and the ovaries, which is seeping, causing the fluid to seep into the most dependent part of the peritoneal cavity. And a presence of adnexal mass, be it a hydrosalpinx or a fluid collection in the pouch of or a pyosalpinx, you will find a adnexal mass. So all these are indirect evidences of pelvic infection disease on ultrasound. Now coming to laparoscopy. Yes, definitely laparoscopy strongly supports the diagnosis. Nothing like just seeing it on the scope and seeing that, oh, this is pelvic infection. Very nice to see everything, but it's very difficult to operate upon sometimes the difficult adhesions of tubo-ovarian masses. It is not routinely done because of its cost and invasiveness. The Fietz-Curtis syndrome, that is, as the picture on the slide shows, that the adhesion between the liver and the peritoneal surface, typically the violent sting appearance is seen in case of gonorrhea and chlamydia infections, where in the severe stages there is fibrosis